Sorry about the technical difficulties. I hope everyone can hear and see me now as we start this first community outreach session talking about anterior total hips and robotic total knees. There will be a question and answer session at the end if you have questions. And feel free also to send in questions via the chat box, and we will try to address them as we go as well. So a little bit about my practice first. I joined this group about 6 months ago in September of 2021. We have 2 offices in which I see patients, both in Plymouth and one in Sandwich, in order to be a little closer to the population at the Cape. I do my surgeries only and exclusively at Beth Israel Deaconess Plymouth Hospital, which is a center for excellence in joint replacement. We have 2 2 robots that perform total knee replacements there, and full capability of performing hip surgeries in all different approaches, including revision complex surgeries. My scope of practice is very limited to hip replacements, knee replacements, and revision hip and knee replacements. So that's all I do. Occasionally, I do take care of fractures as well, because I take orthopedic call at that hospital, but my niche is basically restricted to these 3 kind of procedures. A little bit about myself. I was born and raised outside of the country in Brazil. I'm originally from Brasilia, which is the capital of Brazil. I went to med school down there, a 6-year program. And throughout about the middle of med school, I decided that I wanted to pursue surgical training in the United States. So I prepared myself for that. About a week after graduation, I was fortunate enough to get a job at the Cleveland Clinic doing research with the goal of staying here for surgical training. I didn't know what I was getting into, to be very honest with you. I got to know after my first trip to Cleveland that of the about 650 spots for orthopedic surgery in this country, only about 3 or 4 were typically foreign grads like myself. So that was a tough mountain to climb. After about 2 years doing research at the Cleveland Clinic, only in hip and knee replacements as well, we published about 20 papers, mostly on the longevity of implants, on the failure modes, why they get reoperated sometimes, on all sorts of complications, and also on new devices pertaining to hip and knee surgery. After 2 years doing that, I was fortunate enough to get a orthopedic surgery residency position also at the Cleveland Clinic. That was another 5 years where we rotated basically through all of orthopedics. A year later, I went to Philadelphia, and here I spent a year doing only hip and knee replacement surgery, as well as complex hip and knee revision surgery. So we did more than 500 cases during this very productive year at the Rothman Institute, which operates out of Jefferson University Hospitals. It was in this hospital that I learned to do the anterior approach, the one that I've carried with me to practice, and I will talk about with you today as well. Personal life, I am married, and we have been married for almost 10 years now. I have a 9-year-old daughter. Her name is Liz. She was born in Brazil, and she came with us throughout all these journey in the US. There was a lot of going back and forth, so she had to be pretty resilient. And then Hugo was born here in the United States, used to the winter. And we've been here living in this area for 6 months now, and we love it. It's been very nice. We've been welcomed by everybody, so we're very happy and hope we will stay here for many, many years now. I do not have any disclosures related to the stock. I do not have any shares or stocks related to the Stryker company, which is the company that makes the implants that I use in my practice. And the basic topics that we're going to talk about today are: number 1, understanding what causes joint pain, and what are your treatment options once this problem is diagnosed. Then we'll dive into a little more detail on the different types of surgery for both hip and knee replacements, and why I chose to perform direct anterior for hips and use robotics for knees. I think this will be the basic goal of the talk, to try to make you understand out of all the different possibilities and alternatives of both hip and knee surgery, why I chose to stick with these 2, and why do I think that they're the best solution for my patients. So your hips and knees, they're involved in almost every activity you do. The last thing I want as a orthopedic surgeon is to convince or to push people to have surgery. All I'm here for is basically help people achieve their full potential. If you have a hip or a knee complaint, I do encourage you to seek an orthopedic surgeon, at least to get some answers, to get diagnosis, and to get some treatment options. Surgery is always a last resort treatment. And the last thing I want to do in my life and in my practice is push surgery into patients, or try to do a treatment that is more invasive than the patient is willing to commit to. So we do reserve these procedures only to those who truly need it. And there are very strict criteria as to the indications of hip and knee surgery. And I always try to keep myself to those, as this is the only way that we will have positive outcomes in this field. The most common causes of joint pain. So by far, the most common cause out of these three that you have listed here on your slides is osteoarthritis. Okay, so osteoarthritis is wear and tear of the cartilage that cushions the ends of the femur bone and tibia bone for your knees, or pelvis and femur bone for your hips. I always tell my patients that there are basically two things that determine whether or not you will get arthritis in your life. And that is, number one, the sort of activity you do, meaning how much do you actually use your joints throughout your life? Are you constantly pounding daily on those joints with labor or being an athlete, for instance? And number two, genetics. I mean, that will determine the quality of your cartilage and how long and how fast it will wear off. So why do some people present with bone-on-bone arthritis at 50 or 40s, and then we see 90-year-olds who have very little arthritis? So it's a lot of genetics as well. And on the top of the screen here, you see rheumatoid arthritis. This is less common. It's also called inflammatory arthritis, and it's an autoimmune disease. It's basically your immune system destroying your own cartilage. So it's a more systemic disease, typically affects multiple other joints as well, not only hips and knees. And the newer drugs that our colleagues, rheumatologists, are now prescribing patients who have this diagnosis has actually drastically changed the outcome of this disease. A lot of these patients with RA do not actually get to the point of end-stage arthritis because our rheumatology colleagues have intervened appropriately and early, so they don't get to the point that they used to 20 or 30 years ago. And then on the bottom of the screen, you see post-traumatic arthritis. That is less common, but we do see it every now and then. This happens when you have a fracture, or your bone breaks at the joint, and when it heals, it doesn't heal perfectly. It almost never heals perfectly. There's a little step off. And because of that little malalignment, that joint will become more prone to develop wear and tear. So that's what we call post-traumatic arthritis, when you have a fracture within the joint space. What are the non-surgical treatment options for pain caused by arthritis? There are several. Number one, walking aids. They may allow you to put less pressure on the affected joint and thereby allow you to do the activities you like, and potentially buy you a lot of years avoiding the operating room. Heat or cold therapy. This is also a simple thing that can provide pain relief and thereby allow a lot of patients to do the activities they want to do in a tolerable amount of pain. Physical therapy, very important. It's strengthening the joints around the muscles around your joints. In case of the knees, your quadriceps, your hamstrings, and your calf muscles. By strengthening those muscles, you provide dynamic stability to the joint. So your tendons, they act as stabilizers of the joint, and thereby you're putting less pressure on the joint, less weight on the joint, and thereby it hurts less. So that's a very effective strategy to deal with arthritis as well. Over-the-counter or prescription anti-inflammatory medications. This brings inflammation down. So at the end of the day, what causes the pain is the lack of cartilage that creates inflammation, that thereby creates swelling and pain. So these over-the-counters, they combat the last step in that chain of events, which is the inflammation. One thing that this slide does not include, and I would also like to talk about, is injections. Steroid injections, or both gel injections, but steroid injections more than anything else, is also a very effective treatment method that can keep patients off the operating room table for many years. A steroid is nothing more than getting a whole bottle of ibuprofen or Motrin and injecting that directly into your joint with minimal systemic side effects. It's very safe so long as it's done with the appropriate intervals, more than 3 to 4 months. So by having intermittent injections, 3 or 4 a year at most, a lot of patients can avoid surgery for a long, long time, and that's a positive thing. You know, surgery is always a last resort treatment. It's very successful, but it cannot be used indiscriminately. So when to consider surgery? So those are a few of the questions you need to ask yourself. It's never black and white. And it's always not only it's something that needs to be discussed with a patient's family overall. You know, it's a long recovery process. It can be very taxing on the family and on the caregiver. So it's definitely something that needs to be discussed, needs to be planned in detail and in advance, and needs not to be rushed into. So is the joint pain affecting your ability to get a good night's sleep? Does the joint pain keep you from doing the things you want to do? Does it keep you from exercising? Are you becoming less healthy because of your joint pain? Are you becoming sedentary because you cannot stand to get up and walk anymore? Is your pain affecting your ability to walk upstairs? Or for knees more specifically, is it affecting your ability to fully straighten out your leg or bend your leg when you sit down, for that matter? For hips, is it affecting your ability to put on socks? Or is it affecting your ability to put on shoes? You know, those are very important things that you need to be asking yourself. And as you start to give them up, your quality of life also starts to decrease. And at some point, you need to ask yourself, when is enough enough? So moving on now to total hip replacements. Just a brief introduction before we start talking about a direct anterior approach. Okay, so on your left here on my screen, you can see what a healthy hip should look like. Okay, so the hip is a ball and a socket joint. I'm not sure if you can see the arrow of my mouse here. This is the ball of the joint, which is the femoral head, and it's lined with this white articular cartilage here we call hyaline cartilage. And the inside of the socket there on your pelvis is also lined with the same cartilage. You know, so as you start to wear and tear the cartilage on your femoral head and on the acetabulum, meaning the hip socket, it starts to look more like this. And at some point, the entire layer of the cartilage is worn out and the bone is exposed under it. And then the bone on the femoral head starts rubbing with the bone on your socket, on your acetabulum. One thing that you do not see here is bone spurs. That can happen as well. And then you start having what we call impingement. So on your left-hand side here, you have the image of what a healthy hip should look like in an X-ray. Here you have a nice round femoral head and a nice socket, which is this white line right above the femoral head. I hope you can all appreciate that where I'm pointing out with my mouse. And you can see that there is a space between the ball and the socket right here. And this space is sort of regular and linear throughout the joint line. Okay, and the reason there is a space is because this is filled with cartilage, and we don't see cartilage on X-rays. So that's why we see a space. So when you see a space, that's a good thing. On your right-hand side here, you see no space. You see where the socket is right here, touching the femoral head. So that means that the cartilage layer has gone. At this point, it's analogous to a situation in a car where the entire rubber on the tire has worn out and you're riding on metal. The bone becomes very dense and sclerotic. That's why you have all these changes here, all this whiteness. And you start developing some cysts as well, which is these darker areas within your bone. So this is a very advanced arthritis. This patient is in pain. So how does a hip replacement work? What do we do in surgery that basically solve this problem? Okay, and it's very ingenious the way that hip replacement surgery has evolved over the years towards less failure rates and improved outcomes. And it's amazing how well this works. So the number one part of the surgery is actually getting access to the hip. And we're going to dive into this a little later. And this is where the direct anterior part of it comes in. So you can access the hip from the front, from the side, or from the back. No matter how you do it, once you get there, the first thing you do is you perform a bone cut right over here, and you take that diseased femoral head and you actually get it out of your body. The femur bone is hollow, so we fit a stem inside the femur bone. This stem is made out of titanium, and we remove all the degenerated bone also from the socket size and place a titanium cup in there. We then pop a ceramic head on the taper and a plastic liner on the cup, and we bring the joint back together. So this is done, over 300,000 hip replacements are done every year in the United States. And the reason we do so many is because it works. Here is what it looks like after the surgery is completed. So again, if you just look at the other side, what was done here is a bone cut was made right here. The entire femoral head was removed from the patient's body. A titanium stem was fit into the canal, and a acetabular component or a shell or a metal shell was fit into the socket part of the joint. So this is what a hip replacement should look like. These are the parts of a hip replacement in case you have a little more curiosity to see exactly how it looks like. This is the stem. It's made out of titanium. And this porous part over here is what allows your own bone to ingrow into the stem and thereby obtain fixation. Okay. On the socket side is the same thing. This is a porous material. It's 3D printed, and your bone is able to grow within these little holes here and thereby obtain excellent fixation. Then we snap a plastic inside this cup, which fits perfectly, and a ceramic head onto the taper here on the stem. And then we bring everything together. And instead of having a bone-on-bone joint, now you have a ceramic on a plastic joint. And there has been a lot of research and a lot of story on why we use ceramic and plastic. And this just has been shown as the best bearing surface to last longest and fail the least for hip replacements. And believe me, many things were tried before we got to this point. And now we can ask the question, so why do I do my surgeries anterior? So what we're talking about here is surgical approach. Okay, so how do we basically cut the human body in order to access the hip joint? What is the least invasive method to do that? And the safest method to do that to obtain adequate exposure and be able to perform the surgery safely. There are three main approaches that are currently used around the world for hip replacements. And you may ask me, why are there three? And the reason is because basically they all work. That's the bottom line. If there was one approach that worked significantly and that worked significantly better than the other ones, meaning there was a lot of advantages and no disadvantages, everyone would migrate to that joint, to that specific approach. The reason why we still have three approaches which are currently used in the country is because the long-term outcomes are still the same. No matter what approach you do, if you do a good job in surgery, your outcomes are going to be good. So I think that that's one of the bottom lines that you have to walk out here. I like to be very honest about these things. Okay, the reason why we still have three approaches in this country is because they all work as long as a surgeon does a good job in surgery. Okay, if it was unsafe, then nobody would do it anymore. Okay, so the posterior approach is the one you have here on your left. There is a curved incision which is placed in the patient's buttock, and here you see this large muscle, which is the gluteus maximus muscle. This muscle is split in half in order to access the hip, and then all the smaller muscles inside, they're called the short external rotators. They are detached from the bone in order for you to get access to the bone. So it's an excellent approach. It gives you great visualization of the joint, but it does cause a lot of muscle damage. The lateral approach here cuts through what we call the IT band, and also through your gluteus medius and your gluteus minimus muscle. So there's also a lot of muscle cutting here. It's an excellent approach. Again, a lot of surgeons use it, very reliable, good outcomes in the long run, but there are two a little more aggressive approaches compared to the direct anterior approach, which you see here on your right-hand side. You see that our incision lines are between the muscles on the front of your thigh. So we don't need to go through muscles, as you see here on the left and on the center of your screen. We go in between two muscles. One of them is called the TFL and the other one is called the sartorius. We push them apart and then we push two other muscles to the sides on the deeper layer. And then we have access to the hip joint without having to cut anything. So why do I do it? And there are several reasons to why do I do it. Number one, it minimizes soft tissue impact and helps achieve a better functional outcome, especially early on in the surgery. So the recovery, when you cut less muscle, when you do less soft tissue damage, it basically means that your patients are going to recover faster. Your patients are going to require less pain medications, and your patients are going to have a more normal gait, a more normal walk after we're all said and done with the surgery. Eventually, again, at 1 year, the outcomes of hip replacements, no matter what approach you do, they're similar. Okay, this just brings you there a little faster. It causes a little less pain, a little less trauma, and it makes you walk a little more normal following the surgery. The other reason I do it is for dislocation issues. Okay, so the direction where hips tend to dislocate is through the back. You operate through the front, you minimize that a little bit. So this is also very protective against your hip popping out of the socket. And why is there now such an emphasis in the media and in surgeons on the direct anterior approach? Again, it's the only approach where you don't have to cut through muscles. You go in between muscles that receive innervations from different nerves. It is performed with a patient lying on their back. So that facilitates a lot the job of our colleagues, anesthesiologists, that you don't have to place patients lying on their sides in uncomfortable positions during the surgery. And it also allows us to measure the leg lengths a little more accurately during surgery. If you're lying on your side, then the top leg falls over the bottom leg, and you have an inclination that you can't compensate for when you are assessing leg length equality. When you are laying down on your back, you can actually straighten both legs out, put their ankles together, and you have a much more accurate assessment of how long or short your your operative leg is in relation to the other one, and thereby you can make them equal again more reliably. And you may be asking, okay, that's all very encouraging, doing this surgery with minimal invasive technique, but what does the research say? What does the study say? And there is hundreds of studies on direct anterior approach to the hip. I hope not to bore you to death here. I'm just going to go in a couple of them to show you what I'm talking about. The majority of studies focus on four things. Number one, how much muscle damage. Number two, how well patients walk after surgery. Number three, how many of these patients are dislocating. And number four, patient-reported outcomes, which basically means the questionnaires that patients respond to after the surgery, showing how satisfied they are with the whole thing, okay? So in terms of muscle damage, these are just three important studies done with different methods that compared an anterior approach with a posterior approach. The first study here on the top, some surgeons from Indiana, they performed this surgery in cadavers, and then they basically inspected the muscles and see how much muscle disruption was done after an anterior approach versus a posterior approach. And you can see there the amount of muscles disrupted using the back or the front approach. Two muscles on the anterior approach are pushed to the side but not cut. And on the posterior approach, you have to actually go through several and larger muscle groups. The second study, they looked at MRI. So they have patients done through the two approaches from the back and from the front, and they put everybody in an MRI scanner, and they see how much soft tissue damage those muscles had after surgery. And the posterior approach had more fatty atrophy, meaning more degeneration, more tears, and more fluid buildup. The last study, they had patients do surgery both from the back and from the front, and they took blood markers, and they analyzed a marker that shows a marker of muscle damage. It's called the creatine kinase. When you have a lot of muscle tearing, this goes up in your blood. And it was higher for those who had surgery from the back, both in postoperative day 1 and postoperative day 2, compared to the direct anterior approach. And now there's other study that basically shows how well patients walk after surgery. So they did a 3-dimensional motion analysis to compare stairs between going from the side, going from the front, and also patients who did not have surgeries, patients who had healthy hips. And they saw that going from the front provided patients with more similar kinematics to controls, so patients who did not have surgery, compared to those that were done from a side approach. And then this last study here is what we call a meta-analysis. Okay, a meta-analysis is basically the combination of multiple other studies in the literature. Okay, so we basically aggregate the data, we add up all the patients that were used in several other studies, and we compile those results and do a combined statistic. So this is the highest level of evidence that you can get in the literature. And this meta-analysis here compared the anterior approach with the posterior approach. I'm sorry if this bores everybody to death, but I think it's just important to show that there is actually a lot of data on this. And looking at dislocations, you can see here that this diamond, which shows the compiled data, favors the anterior approach, less dislocations when we add up the results of all these studies for patients who underwent anterior approach compared to posterior. The same thing here, same study, now looking at length of hospital stay. A shorter hospital stay favoring the anterior approach again compared to posterior approach. So that's very compelling data. Again, and then this is the last slide. This is the last boring slide on data, I promise. These are just 3 randomized control trials. So this is the second highest evidence of medicine, medical studies we have out there, prospective. So patients being randomized either into having surgeries from the back or from the side or from the front. And then after a certain follow-up period, we basically check on them and see who's doing better. So a randomized clinical trial from Thomas Jefferson University, another one from Mayo Clinic. This is from the Australian Registry, which is the largest joint registry in the world. The largest database of joint replacements in the world is from Australia, and multiple of them similar to these show favor the direct anterior approach over other approaches. So it's definitely not something that we are pushing into patients here. It's something that is actually very well backed up by concrete data. So what are the conclusions of all this? So number one, like I was saying before, when the components are appropriately positioned in surgery, when the surgeon knows what he's doing, no matter what the approach is, the clinical outcomes are going to be favorable. Okay, that's the bottom line. Do we have a faster rehabilitation with a direct anterior approach? Is there an improved short-term outcomes? And is there lower dislocation rates? It appears that yes, according to all this data, the yes is the answer to that question. But the bottom line is, as long as you trust the surgeon, as long as the surgeon does a good job, your outcomes are going to be positive regardless. Moving on to total knees now. So a little bit about knee anatomy. We did this for hips. I'll do this for knees real quick. So this is what a healthy knee looks like. Okay. The white here again is the cartilage. These structures in the middle are the menisci. And on the sides, you have your ligaments, okay? This is the kneecap right here. So this is what a healthy knee should look like. A degenerated knee, an arthritic knee, in other words, is when the cartilage is worn out, is when the cartilage is, when you do not have any more cartilage, and now you're rubbing the femur bone on the tibia bone. Okay, it's very similar to the hips, and the causes are the same. Those 3 causes, the osteoarthritis, the simple wear and tear, or the rheumatoid arthritis, which is the autoimmune disease, or the post-traumatic arthritis, they all come into play here. This is what a healthy knee x-ray should look like. Okay, so on top here, you have the femur bone. This round structure right here, this is the kneecap. On the bottom, you have the tibia, which is this large bone here on the bottom of your knee. And on the side here is the fibula. And you can see the space between the bones right here and right here. So this knee here has preserved space. So that means you still have a good layer of cartilage. Okay, you probably still have a good layer of cartilage and you still have intact menisci. And now here you see an arthritic knee. So you can see the difference, how you have a preserved space here on the outside of the knee and no space here. You have very dense white looking bone, which means diseased bone. And you have some bone spurs there too. So I know that here you don't have any more cartilage. You likely don't have any more meniscus. If you do an MRI of this knee, there is going to be a lot of degenerative meniscal tear. Okay, but the meniscal tear is not the actual problem. The actual problem is the arthritis. Okay, which is the lack of cartilage, not the lack of meniscus. Weight loss is very important, especially for knee arthritis. Every 1 pound you lose, you take off 4 pounds from the joint because you are constantly alternating your weight bearing. You're putting all your weight either on one side or on the other side of your legs. So losing 1 pound makes a huge difference for each individual knee. And what does knee replacement surgery do? Okay, it's a little different from hips. On knees, you're basically resurfacing the bone. You're not taking a chunk of bone like you do in hip replacements and taking it away from the patient's body. You're actually just resurfacing the bone with metal, a cobalt chromium component for the femur, a titanium component for the tibia, and then a plastic right in the middle of the two. So before, where you used to have diseased bone on bone joints, now you have a plastic, a polyethylene liner that is articulating with a cobalt chrome femoral component. And again, I'm talking about the nature of the material of the implants here, but the evolution of total knee replacements has also been something amazing throughout history. And this is found to be the longest lasting implant and the one that is more reliable. So that's why today we are on cobalt chrome and polyethylene. Okay, on the left hand side here, you see what a partial knee replacement looks like. Some patients only have disease on one side of the joint, and therefore they're candidates for a partial total knee. And it's a very similar implant, but the only difference is the size. Okay, this only covers the inside of the knee, but it's also cobalt chrome, plastic, and titanium. Over 600,000 knee replacements are performed each year, which is a lot more than hips. And the reason for that is because knee arthritis is just more common than hip arthritis is. These are x-rays of replaced hips. Here on your left, you have what a partial knee replacement is supposed to look like. Okay, you have a cobalt chrome femoral component, a plastic in the middle. You don't see plastic on the x-ray. That's why you only see a gap. And then a titanium tibial component. This is what a total knee is supposed to look like. Okay, so you're replacing the entire surface of the bone, not just part of it, like the partial knee replacement. So cobalt chrome, plastic, titanium. This is how it looks on the side. So we're basically resurfacing the end of the bones, both in the femur and in the tibia. Okay. There are several ways to do the, just like with the hips, where you have different approaches. With knees, you have different methods of putting the components in place. Okay, the robot is one of them. Okay, and now I'm going to tell you why I choose to do my total knees with robots. Okay, and the reason for that is with knees, 1 or 2 degrees difference on the way you put that component in the bone can make a huge difference for a patient. Okay, so what the robot involves is having every patient do a CT scan before the surgery. Okay, and then we upload all that information into a software, and the robot is able to predict the size and the appropriate location for those implants virtually with the data provided by the CT scan. So here, if you can see, we can size the implant, determine what size it will be, the millimeters of bony resection necessary to place this implant, and thereby we can do as minimal resection as possible in order to preserve the most amount of bone, and the gaps that we are left with in order to put the plastic insert as well. So we do all this planning before surgery. That's not all. And then during surgery, okay, we actually apply tension to the ligaments on the knee because patients are different. Okay, so some patients are going to be a little more taut, some patients are going to be a little more lax, and that will also play a role in the way that we place our implants. So after all that preparation before the surgery, during the surgery, we tension the ligaments to get an idea of how tight the patient is. And based on that data, based on that information, we do final tweaks with the implant. Okay, so the final adjustments, they're made intraoperatively based on how tight each individual's ligaments are in surgery. And by doing that, we don't have to release any ligaments. We protect a lot of soft tissues, and we are 100% sure that we're placing them in the correct spot. So once we planned it before surgery, we adjusted it during surgery, we're ready to actually do the bone cuts and perform the procedure. To do that, there is a robotic arm that actually moves into the surgery field, okay? And then we perform the cuts almost like a video game, get rid of all the green here. And even if we wanted to stray from the path, cutting on the wrong place is actually impossible. The robot actually gives us a boundary here, you can see on this yellow line, to protect your native soft tissues. So there's no cutting of native ligament inadvertently. There is a lot less chance for mistakes to be made, because whenever the robot strays from the path, it strays from the plan, it simply stops and the surgeon has to adjust. Okay, so it makes for a much more reliable procedure, a much more reproducible procedure, and a safer procedure for our patients as well. And what's the data on Mako? You may say, okay, that those are all very interesting theoretical facts, but does this actually play out in real life? Does this actually work in real life? And the answer is yes. There's a lot of studies that showed lower pain scores for patients that underwent total knee replacements compared with manual. And the reason for that is because you're protecting all that soft tissue around the resection margin. You're preserving a lot of healthy bone. So because we're able to plan ahead of time, we are able to remove only the minimum amount of bone necessary to appropriately place those components. So over the time that the robot's been around, which has been over 15 years now, there has been at least 200 published papers on this. Here it says 145. This is a little outdated. There has been even more, including randomized controlled trials. There's a lot of systems in the United States. The Mako system from Stryker, I do not receive any money for consulting or for doing this talk, is the one who's been there the longest, basically. You know, they have the most amount of data. They've been there the longest. So there's the longest track record. You know, that's why I use this. It's very, very reliable. Recovery from joint replacement, no matter if it's hips and knees, how's recovery like, you may ask. So you do the surgery. Following the surgery, some patients are eligible to go home the same day. Some patients need to stay in the hospital for a day or two. Okay, every patient gets physical therapy. I usually say that for the first 2 weeks, it will be rather painful. Your pain is probably going to be around a 4, despite all the medications we give you. Knees are a little more painful than hips, especially hips done from the front. The pain tends to be actually very tolerable, very manageable. You follow up with me at 3 weeks and at 6 weeks. And after that, a 1-year follow-up. Obviously, if anything goes wrong during that time, I always leave an open channel so that my patients have a direct access to me and they can come back anytime you want. Again, although every individual is unique and treatment plans are different, general recovery times is in hospital recovery between 1 and 4 days, especially with COVID and with the recent push towards outpatient surgery. This is decreasing by the day. About 40 to 50% of my patients go home the same day. Another 40% goes home post-operative day 1, and maybe 10% or so stay 2 or 3 days. Okay, activities following surgery, you're encouraged to walk from day 0, do a couple of steps while you're still in the hospital. At 3 months, you're 90% recovered. Okay, so at 6 weeks, you'll be mostly doing everything you want to do, but every time you overdo it a little bit, it may be a little sore. At 3 months, you're 90% recovered. At 12 months, you're 100% recovered. Walking, driving, biking, swimming, golfing, and dancing, those are all activities we want you to get back to after surgery. This is all not only possible, but doable and encouraged. Okay, we want you to get back to your normal life. We want you to do these activities. We want you to be independent, hopefully free from walking aids. The only thing we don't want you to do is high impact activities. It's not that you won't be able to, you might actually if you were doing this before surgery, but these are the type of things that may decrease the longevity of your implants. So we tend to avoid patients not to do these things. If somebody is adamant about skiing, running, contact sports, basketball, jumping, then I probably advise them to delay their surgery until they are okay with not doing these things anymore. Okay, so I have 3 questions here. Let me see. Is there a reason a patient might not be appropriate for the anterior hip? That's a great question, and the answer is yes, there is. Number 1, revision surgeries. Okay, revision surgeries, there are very few indications for anterior hips. I tend to do most of my revision surgeries from a posterior because despite it being a more aggressive approach in terms of muscle cutting, it does afford me a more extensile approach in case I need more access to the femur, more access to the pelvis. Another contraindication to anterior hip is previous hardware. So if a patient had previous hip surgery, has a nail or some screws, I tend to go from the back as well. Okay, those are the 2 big ones. So more complex surgeries that will need a more extensile approach, then I tend to do a posterior approach in that. What are the disadvantages of the anterior approach? Why isn't anterior approach universally used given the advantages discussed? That's a great question. And there are disadvantages to the anterior approach. And I will list them right here, right now. Number 1 advantage, they are a little trickier to do. So if surgeons did not receive specific training on the anterior approach, either on the residencies or fellowships, it can be very challenging to have adequate exposure of the femur to perform the procedure safely. So that's why many surgeons are not willing to stop doing something that works well, which is the posterior or the direct lateral approach, to switch over to the anterior, because it's a very tricky procedure after you get through the learning curve. And the learning curve of the anterior approach does incur in you having some patients with some complications like fractures and things like that. So a lot of surgeons, and very rightly so, they're just not willing to put their patients through that. Okay, so if they have not received usually specific training, a lot of them are reluctant. And another disadvantage of the anterior approach, number 1, like I previously said, it does not allow you a more extensile approach if you want to do revision surgery. Number 2, there's a little skin nerve that crosses the incision site on the front of the thigh that gets irritated with the anterior approach. So some patients complain of a little patch of numbness on the side of the thigh after the surgery. That usually recovers in over 97% of patients, but some patients have a persistent numbness on the side of the thigh. It's not a nerve that goes to muscles, it's just skin sensation. So it tends to be a minor issue. Those are the big ones, disadvantages for the anterior approach. Another question, is a CT scan for the robotic knees covered by insurance? We are having issues with that lately. Most insurances do cover it. Some patients, depending on what insurance they have, are having to pay some out-of-pocket costs for this. So it's a very insurance-dependent question that will have to be addressed individually with each patient. How long to wait between a second hip surgery? That's a good question. So actually, some surgeons in this country are actually doing simultaneous hip surgeries. Do one side and the same day, same time, do another side. I don't do that. The complication rates are a little higher. I don't want to put my patients through that. If everything goes uneventfully, if the recovery is excellent, and if there are no complications, I tend to wait at least about 6 to 8 weeks, but typically around 3 months until the patient is more recovered. You know, like I said before, at 3 months, you're 90% recovered. So at 3 months is usually where I go for if the patient is in severe pain or has severe deformity on the other side, which is affecting his ability to walk. Then we can do it, I'd say 6 weeks at the minimum. Next question. What advantage is there to intraoperative nerve monitoring? We do not operate close to very dangerous nerves like spine surgeons do. I do operate close to the femoral nerve, but we are careful enough to keep it well away from where we work. So intraoperative nerve monitoring isn't really a requirement after hip replacement surgery, just because the rates of nerve damage after surgery are so low, are less than 0.1%, and nerve monitoring has not shown to decrease that anyway. So it's not something typically done with hip replacement surgery. What is the infection rate? That's a good question, about 1%. So it changes according to patient risk factors. Obesity is a big risk factor. Diabetes is a big risk factor. Bleeding disorders are a big risk factor. And patients who have these issues can have a little higher infection rate. The general answer is about 1%. If you're healthy, if you're thin, if you're not diabetic, if you don't have a bleeding disorder, it's a little low. The average is about 1%, but it can be as high as 5 to 10% in some specific patient populations. Especially if you had a previous joint infection, then you're more likely to have a future joint infection as well. So it varies, but the general answer here is about 1%. Okay, we covered a lot of ground and answered a lot of questions. If anybody wants to unmute themselves and ask questions orally, feel free to do so.
I have a question.
Yes, go ahead.
What are the precautions post-operatively?
For hip replacements, that's one of the advantages of doing anterior hips. No precautions after surgery. So usually after posterior hip replacements, surgeons do not like patients flexing the hip beyond 90 and internally rotating the hip.
Right.
After anterior hip replacements, because it's so intrinsically stable, we're not violating any of those tissues on the back of the hip, which is usually where the dislocations occurs. There's no precautions after surgery. They're just not necessary. And there's research showing that patients who have precautions compared to those who have not have no different rates of dislocations. The overall rates of dislocations after this surgery for anterior approach is probably about 0.5%. We do not change that by doing hip precautions, so we don't.
Thank you.
I have a question.
Yes.
For relief of discomfort, is it better to use cold therapy or warm therapy? I've had doctors say whichever feels better, but I'm wondering which is more beneficial.
So my opinion on that is early in the post-operative recovery. So on the first couple of days after surgery, at least on the first week, I'm all for ice and no heat. For acute inflammation, heat makes it worse, ice makes it better. After the acute part of your inflammation has gone, for chronic pain, either arthritis or late recovery period, then I am more of whichever feels better, and probably alternating at the chronic stages, but acutely ice and no heat.
Thank you.
I have a question.
Yes.
I already have a hip replacement that has to be replaced. How's the success rate of that?
That has to be redone, you mean?
Yes.
Yeah, so I mean that will depend on a series of factors. Number one, what has to be redone? Is it the cup side? Is it the femoral side? Or is it both? What was the approach used on the original surgery? And what is our plan in the revision surgery as well? What do we intend to do? So most likely the revisions, I do it from the back. But if it's something simple, if it's only on the socket side of things, and if your original approach was from the front, then we can maybe do it from the front as well. But there's a lot of variables there that we need to talk about more specifically.
Okay, thank you.
If someone needed a hip replacement and a knee replacement on the same side of the body, which surgery would you do first?
That's a great question. And that's a situation where we encounter often. I mean, number one, there are some patients that have specific preferences. You know, so some patients have, the knee has always hurt a lot, like a 10 out of 10, and the hip is a 2 out of 10. But in general lines, so number one, there's an individual discussion with each patient to get a plan. But in general lines, if you have a bad hip, the pain from the hip arthritis can be felt not only at the hip, but also at the knee. So just the way that your hip is wired, your nerves, sometimes by addressing the hip, the pain at the knee is taken care of as well. So I tend to do the hip first. You know, sometimes we do the hip and the knee pain also goes away. So that's why we tend to do the hip first, and then we see what's left and go from there on whether or not we need to do the knee.
Thank you.
Any other questions?
I'll ask a question. Can I ask a question about knee replacements? What percentage of patients who get knee replacements find themselves dissatisfied with the results? And the reason I'm asking is that I used to be a very physically active person and had a fall. Was diagnosed with a meniscus tear, and the recommendation was to have that knee scoped, which it was. And a year later, developed arthritis in that knee. There's been talk about getting a knee replacement, but there's also been told that there's concern that people in my situation often find themselves dissatisfied with the surgery, and was just wanting to get your thoughts on that.
Yeah, that's also a great question. So number one, when you have, depending on your pre-existing level of arthritis at the time that you had your arthroscopic surgery to deal with the meniscus, sometimes a huge part of the meniscus is removed, and thereby it actually worsens the pre-existing arthritis. You know, when you take out some meniscus, your arthritis progresses faster after that. So that's actually a common scenario as well. Knee replacements, they're a little trickier in terms of outcome compared to hip replacements. There's actually a lot of data on the exact question you just asked. And the bottom line for that, the hard answer is about 15% of knee replacements are not completely happy with their surgery. Okay, that's why we have to be very careful about the correct indications here to see if you're bone on bone, see exactly how your x-ray looks like. If you do it for a not so severe arthritis, especially in the knee replacements, about 15% of those patients, they say that their knee are better than what it was before, but it's not perfect. It's not what they were expecting, and they're not entirely happy with it. You know, so that's a very fine line we have to walk in terms of indicating those surgeries. And most of the times when that happens, I see a lot of patients as well who had hip and knee replacements done in other hospitals by different surgeons and have persistent pain and come to me asking whether anything can be done about it. And a lot of time we investigate for infection, we see whether the implants are stable, we get CT scans to look for alignment, and everything looks good. You know, the ligaments are working, the implants are well fixed, and there's no infections, and there's no good answer for it. And those are the 10 to 15% of patients that they don't have a clear reason to have persistent pain after the knee replacements, but they're not completely happy. So to answer your question objectively now, after knee replacements, about 15% of patients are not completely happy with the results. The rates of the same thing happening with hips is much lower, actually. It's a more successful surgery. I hope that answers your question.
Thank you.
Hi, could you speak about the anesthesia? I understand they've made great strides in the type of anesthesia used.
Yeah, so there has been a recent push on the recent past to move towards spinal anesthesia. And the reason for that is because, again, it's less invasive, it provides excellent postoperative pain control, and the rehabilitation is faster. With general anesthesia, you need the tube down your throat and you need muscle relaxants, and recovering from that is harder than it is from spinal anesthesia. And not only that, but the whole pain management strategy around hip and knee replacement surgeries have changed a lot over the past 2 to 3 years. As has the push towards outpatient surgery. So because we're sending a lot more patients home on the same day, our strategies to deal with their pain has improved accordingly. So not only does the spinal improve it, we do a short acting spinal that is just enough to do surgery, and then it wears out fast so that you can actually regain your strength to start walking. Number two, we do intraoperative numbing of the surgical area with a anesthetic. It's called Exparel. It provides good local anesthesia for about 72 hours. That has been shown to decrease the rate of opioid pain consumption after surgery. We do a multimodal pain management protocol after surgery. It basically means that we use anti-inflammatories, we use Tylenol, we use some nerve pain medications, and we use a little bit of the opioid pain medications as well. So not only did we move more towards a short-acting spinal, but we also use a whole array of other things in order to minimize opioids and to keep patients comfortable and ready to go home sooner. Any other questions? Are you awake during surgery? So no, you are not. You are awake during the spinal, and then right after the spinal is done, they give you some medications to relax even before the spinal, but you're still awake. You're awake during the spinal. Right after the spinal is done, you go to sleep. You don't remember anything that has happened in the surgery. So you don't have to worry about that. Okay, any other questions?
Do you have any?
So it's been a pleasure. I hope to get the chance to get to know each one of you, and we can definitely give out contact information in case you want to see me in the office. Okay, one last question here. I need multiple joint replaced. Will I be more prone to infection after the first? No, you will not. I mean, if you have one infected joint, then you're more prone to get the others infected. But as far as infection goes, having multiple joints replaced, if you've never had an infection, is not a risk factor.
Thank you, Doctor.
Thank you.
You're welcome. Have a good
Thank
night,
you.
everybody.
Very, very helpful. We appreciate it.
No problem. You're more than welcome.
And it was not boring.
Good.
Thank you.
Thank you.
You're welcome.
I'm leaving. Okay.
I don't know why, but yeah, it says unmute.
Yes.
So, but it wasn't, your voice wasn't going through. So do you know what you needed to do? Obviously you didn't. I wonder what it was, because we want to do Zoom with the kids and writing the newspapers. David or somebody will know, he can tell us what to do. There's nothing here, huh?